So one of the things that the Family Heart Foundation has is a great interest in doing research and having tools to do so. So we have two very important research assets. One is a registry that I run with my colleague, Mary Card, and that registry has over 6,000 individuals who have heterozygous and homozygous familial hypercholesterolemia. At the time of our data cut, we had 67 people with homozygous FH. Remember, heterozygous FH occurs in 1 in 250, homozygous 1 in 300,000. So the fact that we have 67 individuals, adults and children, in our registry is great. We'd like to have more HoFH patients, but we follow their journey longitudinally. 51 adults, 16 children. And we look at what has happened to them throughout their life, and where their untreated lipids were, and where they were at the time that we did the data cut for the study. And then we also have another data asset, and this is a national database, the Family Heart National Database, where we have we have 324 million Americans that are part of that database. It includes procedure codes, diagnostic codes, laboratory codes, and prescription codes. And so of those 324 million, 81 million had enough laboratory data, data on prescriptions, and data on diagnoses that we could look at those 81 individuals and compare them to the people in the registry and say, how many people of those 81 million do we think likely have HoFH, and how are they being treated? So what we can say about the registry is we had 51 adults and 16 children. And one of the things that we noticed right away, that the untreated LDL level in the adults, the median untreated LDL in the adults was 533 milligrams per deciliter. That's super high. The median LDL untreated in the children was 776 milligrams per deciliter. That's off the charts. And we really asked the question, why do the children have such have so much higher LDL levels? And based on all of the data, we do think there's some survival bias, that some adults don't make, the adults with the highest LDLs may not make it into adulthood, because left untreated, the average age of death in someone with homozygous FH is 18. But we also think that one of the major issues, since we're not screening the way we should, is that only the children with the highest lipids come to the attention of their pediatrician. Their pediatrician knows that there's a family history and may screen them, and then they get sent to a lipid clinic. And so this is, I think, a perfect example of how we need to screen everybody, because the untreated LDL of adults indicates to us that, some adults are not being found till they're older. And when we look at both children and adults, those that had the highest LDLs were diagnosed earlier. Those that didn't have such high LDL, maybe had LDLs of 450, 500, they were diagnosed when they were adults and having cardiac events. So in both cases, we want to make the diagnosis early so you can initiate therapy. Then in the Family Heart Database, where we had 81 million Americans that we were evaluating, we found 277 that looked like they had homozygous FH. Their average LDL untreated was over 440. We found that only 25% of them had been diagnosed with FH. So 75% had no diagnosis code that said they had FH. We found that 40% of them were on no lipid lowering therapy. And we found that 84% of these people were under the age of 50, so they were young, and 20% already had cardiovascular disease, and many did not have a diagnosis. So in the real world database, things are even more dire than in our registry. If we think about the clinical implications, one of the key takeaways is that we should be doing universal screening at an early age so that we can make the diagnosis in each and every child so that they can become healthy adults. So universal screening is important. We know that when individuals got into the registry, they were on fewer medications than when we evaluated them at the end of their last visit. And so we know that in order to be effectively treated, children and adults with homozygous FH require 3, 4, 5, and even 6 lipid-lowering medicines to get their LDL to goal. And so it's really important to level set things with parents of children with HoFH and with adults with HoFH, that you're going to require multiple medications, but we now have all the tools we not all the tools we need, we still need more medicines, but we have the tools that we need to get most people well treated. We also have lipoprotein apheresis that can physically remove LDL cholesterol. And then we think there needs to be an increased awareness of both heterozygous FH and homozygous FH, an awareness that if somebody is screened with a lipid panel and they have an elevated LDL, significantly elevated LDL, greater than 400, the clinician should be thinking, could this be HoFH, and delve deeper, get a better family history and look for physical findings. Not everybody has them, but you can see cholesterol deposits in the tendons. You can see cholesterol deposits around the cornea of someone's eyes called corneal arcus. So good physical exam, good family history, and a really healthy level of suspicion when you see somebody with a very elevated LDL.